everybody, and welcome back. I really hope you can hear me. I'll speak nice and clear, as will my colleagues Katie and Sarah. I'd like to introduce you to our scenario, and this is live in the ED department. We've moved into resus, a baby who is 4.8 kilos, who is 2 months old. No previous history, no antenatal or postnatal diagnosis, nothing untoward with this baby. Mum's been concerned about him over the last 24 hours, just not taking his feeds, quite irritable. And then today, she, the early part of this morning, after not taking his feeds, she undressed him, and she just described sort of a bounding chest wall, fast heart rate. She can feel his chest when she's trying to console him and cuddle him in. So as I said, we've brought him into ED, resus, and we'll work through our sim, and we'll see you at the debrief. Thank you.
It's not a great colour, Sarah. I'll put some optional. While I do, will you put some ECG dots on for me? I'll just start with my assessment. So we are self-ventilating that 15 litres of oxygen. We have a respiratory rate of around about in the mid-30s, with minimal increased workup breathing. Cardiovascularly is currently enters with a peripheral capillary refill of 5 seconds and a central cap refill of about 3 seconds. Heart rate is very fast, but we're in SVT at the moment, so can we get a hand, please?
Hi, I'm Kay. I'm the paediatrician on for today. What's going on?
I've got a 2-month-old baby that is in SVT at the moment. I just needed some help.
Okay.
We're looking at the stable side of the algorithm because he is self-ventilating and he does look okay. So we just needed some advice and some help, please.
Yeah, absolutely. So, can we do a blood pressure, please? So, yeah, can't see any obvious P-waves. 12-lead ECG on for simulation purposes. Saturating well. Stable at present. So, can we get some ice, and we'll try 30-second ice to the face, please. And just continuous structured assessment throughout Katie, please. Sarah, could you get some IV access for this baby, please? And Mum is she just
stepped out.
Okay. Okay. So let me know when you've got that IV access in, Sarah. Around 30 seconds on the ice.
30 seconds done.
Okay, is very shut down. If I can't get this in, can I use an IO? Yes, if we move into sort of unstable, that would be very useful, but not if we're thinking about adenosine. Doesn't get to the heart quick enough. So give me a go with that IV, and if not, I'll give it a try myself, Sarah. Okay, we're in. Fantastic, thank you. So we've got IV access. Ice hasn't really worked with this baby. We'll not go with vagal manoeuvres. We'll just move on. We'll try some adenosine. So can we get adenosine ready with a 3-way tap, Sarah, for fast administration? We'll go 100 mics for the first dose.
That's 100 mics of adenosine, which is 480 mics.
Yeah. Okay. So 4.8 kilos, 100 mic. So we're going to give fast administration, Sarah. Can you just let me know when that's in?
Okay, so a 3-way tap, large flush. Happy?
Yeah, adenosine
in, flush in.
Katie, we'll just give that a couple of minutes. Katie, any change in the baby's assessment?
No change, still the same.
Okay, so it doesn't look like that had. Sarah, can you get a 200 mic per kilo dose ready, please? We'll just give that another.
So that's 200 mics per kilo of adenosine, that's 960 mics. So 3-way tap again.
Katie, can you just run another blood pressure as well, please?
Yeah.
Large, just hold on there. Sarah, are you ready? Just get a blood pressure. Alright, that's around 2 minutes there. Just get that blood pressure on.
We've got emergency equipment as well ready, haven't we?
Okay, so we've got an emergency trolley in the room.
Yeah.
Yeah, and then
got resus drugs,
lovely.
intubation drugs should we need them, and some fluids as well.
Okay, still stable at present,
Yeah,
blood pressure's fine. Okay, go with that second dose, 200 mics per kilo, Sarah.
Adenosine in, saline flush in.
In. Okay, looks like we've got it. that a minute. That looks much better. Sinus rhythm for 135-ish, saturating well. Can we run another blood pressure, please? And Katie, can you do another full assessment, please?
Yeah, so self-ventilating at 15 litres. Respiratory wise has got a respiratory rate of around mid-30s with minimal increased work of breathing. Saturations are in the mid-90s.
Excellent.
Cardiovascularly has now got a capillary refill time peripherally of 3 seconds and centrally of 2 seconds. Heart rate's down to 135 and I've recycled the blood pressure come up.
Excellent.
Visibility wise is alert and is getting mad at me.
Fantastic, fantastic. Well, it looks like we're back in sinus rhythm, stable at present. We'll keep putting for observation for a little while. I'll pop back, I'll go and chat with Mum, just tell her to talk possibly about a cardiology referral and see if there's anything going on with this baby. And thank you very much, excellent work. Thanks, guys.
Thank you.
Hello, welcome back everybody. So Neil, could you come on camera please? And Julie, could you also come on camera if appropriate? Thank you. Some questions. Welcome. Thank you very much. I hope everybody managed to see that and it was good enough quality. We'll obviously get some feedback on that. I'm going to try and speak over the mask, so I do hope you can hear me. So we'll start by saying, what do you think went well?
I think we recognised SVT very quickly. I think we got help very quickly. I think we communicated really well and worked well as a team.
Yeah, it seemed to be quite calm and under control. Does that sort of give you some reassurance when you're thinking stable part of the pathway, and would that have made a difference had we have been on the unstable sort of elements of the pathway?
Yeah, definitely. I think we were quite lucky actually that the patient was stable. Katie obviously did a full 8-day assessment, responded appropriately. We had some oxygen on, and actually he was stable enough to go down to the stable algorithm in terms of treating his SVT. So it was a bit of reassurance actually that he was stable.
So we made reference to some of the emergency equipment. Obviously it's in a resus, but what kind of things sort of would give you that reassurance should the patient's condition change at any point?
I think we know with SVT that things can change very quickly. So we had our resus trolley in there in case we needed to proceed to manage the airway for the child. We had a defib in case we need to move to cardioversion, and then we also had some fluid and some intubation drugs and some resuscitation drugs should we need them drawn up ready on top of the resus trolley.
Excellent. So throughout the sim, I'll bring you in, Neil, here. So throughout the simulation, we did 100 mics, then 200 mics. Obviously, we have a third dose available to us. What would be the course of treatment after that, and what would we advise sort of with regards to cardioversion?
So, I mean, obviously, if the patient's unstable, I would go as quickly as I can to cardioversion. I would, if usually, obviously, it takes time to obtain IV access and time to actually draw up the drugs and stuff like that. And if the patient's unwell and unstable, I wouldn't necessarily waste time there. With regards to the adenosine, so frequently people comment that the adenosine didn't work. So it might be interpreted as the fact that your first dosage didn't work, but actually it did, because it did briefly terminate the tachycardia. Unfortunately, it was just not a sustained effect. And sometimes when you give a second dosage, it certainly does terminate the tachycardia. It's probably not because the adenosine sticks around for a little bit longer. It's just probably we're kind of lucky at that stage. Usually if I find that if a patient like that, that's otherwise stable, if they have failed 2 or 3 dosages of adenosine, at that stage, I would request that obviously pediatric cardiology be consulted, because at that stage, I would usually recommend that the patient be given, if the patient is stable, I would actually recommend that they be given a dosage of a beta blocker to just control the heart rate at least. Often it does terminate the tachycardia, but it means that we've got a little bit of time to be able to kind of get the patient to us to assess the patient. I know that the APLS says amiodarone, consider amiodarone. I would advise against that, partly because it makes my evaluation and management of the patient a little bit more difficult, because if the patient's been loaded up with amiodarone, it makes it very difficult to give them any other medicines during that stage. And certainly, I would think that for the stable patient, we have less, well, we've got options available with better side effect profiles to give at that stage. So I would prefer that. And with regards to if the patient becomes unstable, then yes, then amiodarone would be a consideration. Now, I see that there's a question there regarding if the patient needs to be intubated and shocked or just shocked. I mean, obviously, if the patient's unwell, I would proceed with normal resuscitation. So intubation at that stage is almost invariably required. If you're doing an elective cardioversion, often you are able to have the patient just sedated or kind of sedated for the cardioversion, and they don't necessarily have to be intubated. But in these cases where you do an emergent cardioversion, you're almost invariably going to intubate the patient as well. And then you might be lucky that with intubation that causes a vagal response, and it might terminate the tachycardia for you as well. I've certainly seen that happen as well.
Thank you, that's great. Just going back to the adenosine administration, Sarah, you used a specific sort of technique, and I know that's certainly in the NECTA guideline. Is that quite a fiddly technique? Is that something that you need to practice? It probably is worth practicing. I'm very experienced in using three-way taps because I've used them for a number of years now. However, I think it is worth at least having a look at one, knowing where your arrows are pointing and making sure that you're actually open. The trick with adenosine is it has to be given very quickly, and you need a very, very large flush. So it does require having a three-way tap on there, and it must be administered in that way. Which is why I actually had everything ready there in the tray. So as soon as I had IV access, I could attach the three-way tap, and depending on what route we went down, at least we had that there ready.
Excellent, thank you. There's a question on the chat, Neil, that I'd like you to respond to about IO access.
So IO access for fluids, and obviously some medications is fine. Adenosine, the problem is that you're not going to get the adenosine, because the adenosine needs to go into the coronary arteries as such. So you need to get, and the problem is that it gets metabolized probably within seconds. So if you inject it into the interosseous space, into the medullary cavity, it's going to kind of seep through medullary cavity, and then has to make its way back out of the bone into the systemic circulation, and by that stage, it's been metabolized. So it doesn't work giving it intraosseous, but obviously other medications do. So if one needs interosseous access for resuscitative purposes and potentially having to give medicines, then that would be appropriate, but certainly not for adenosine administration.
Excellent answer, thank you. So
just to sort of round up, because I think we've covered it really well throughout the debrief, is there anything else that you think you could have done differently? Any different approach? Any feedback from the audience? I know there's a couple of comments around sort of dunking the infant in cold water, icy cold water, and we've certainly seen that done. And yeah, I guess one of the things to raise was just sort of knowing where that ice is and how accessible that is within your regions, within your departments. I think that's really important. So every place has a different way of obtaining ice. And where I work, we have these bags that we have in the freezer ready. Not everywhere has those. We have used an ice machine before. So it's really important that you know where you can get ice from. Katie's experience?
We went to Costa.
Costa Coffee. Costa Coffee. Oh yeah, amazing.
Brilliant, brilliant.
How you can adapt to a situation should you need to. So, is there anything else anybody else would like to add to the debrief? Anything you think that no? I think the only thing we said was we were lucky that this patient was stable, but it's really important to have your resus equipment there ready. Yeah, these children can become very unstable at any point during that. If everything's there ready, we always hope that it won't be needed.
Sorry, can I ask one question? So you got your access on the dorsum of the hand. Did you not try on the cubital fossa because it is more near to the heart?
No, in terms of access, sorry. Yeah. You just that wasn't a. I've just put in my first carry.
It is the recommendation, yes, that you have to be close to the heart. But if you've got a good enough vessel, if you've got a good enough vein that you can actually give a good enough chaser afterwards, it should be all right most of the time.
Thank you.
Thank you. A little bit of feedback from one of our participants. Just saying, next time can we please include cardioversion simulations? If that's something that would be interesting, I will do not necessarily a live one, but I'll pre-record a cardioversion simulation if you think that would be useful, and I'll get that out on the network website.
Okay, next time we do one, if we've got any kind of warning, maybe we can record one where we actually do a real life one.
Okay, well, the way things are going, Neil, with the future of telecommunication, I think we'll definitely be doing that real time.
No, but it's good to have one to kind of have one on file then, for educational purposes. Yeah.
Yeah, but in the meantime, we'll do. I'll certainly get that recorded for you and put onto the network website. That's no problem at all. So once again, I would just like to thank every single one of our panel and participants today, and a huge thank you to the audience for your participation. It could have gone very differently had you not have been as interactive as you have been. So thank you so much for joining us in these crazy, unprecedented times. I appreciate you taking the time to join us today in your very, very busy work lives. So without further ado, thank you everybody, and we look forward to seeing you soon. The presentations and the videos will be on our network website really soon, so keep an eye out. Thanks so much. Anything you want in the future, just send me a line, drop me an email, let me know, and we'll get that sorted for you. Thanks a lot. Have a good day.
Bye.
Fantastic weekend.
Bye-bye.
Bye-bye.
Sit tight. Oh well. No, we're still.